sexual health. As part of every relationship, new or long-term, it's essential to be able to communicate and understand how you are affected by navigating barriers experienced by effects of having cancer. So I am your lead. Introduction to me. I've joined the myeloma crowd in 2020 to share my passion for health. My cancer is a childhood cancer survivor, as well as a cancer biologist. Finding cure, better treatments, and living a balanced life is our passion. And I am a mom of an energetic 5-year-old, and I love to practice what I preach. I am so honored to introduce our speaker today. We have Dr. Amy Siston, Ph.D. She is a clinical psychologist at U Chicago Medicine in the Department of Psychiatry and Behavioral Neuroscience. Dr. Siston has specialized in psycho-oncology for almost 30 years and was an integral in building the psycho-oncology service at UCM, where she provides individual therapy to cancer patients throughout the cancer care continuum. Recognizing that sexuality and reproductive concerns of people with cancer are under-addressed in the medical setting, Dr. Siston focused her continuing education in the area of sexual health and cancer, earning certification as a sex therapist from the American Association of Sexuality Education, counselors and therapists. Dr. Siston's research interests involve coping and adjusting to cancer diagnosis and treatment, survivorship, and sexual health. Dr. Siston is also involved in training mental health professionals with interests in psycho-oncology and sexual health, and has frequently lectured on topics of cancer survivorship. So I am so honored to bring her on today. I will stop sharing my screen and turn the time over to you, Amy.
Okay, thank you very much for the very kind introduction. I'm very glad that I'm able to be here this evening on Zoom because we have a heck of a lot of snow out there. I was really worried we were going to lose our power, and this was going to be quite difficult. So I'm very happy to be here this evening. So with that said, let's go ahead and get started.
Perfect.
And I will just get my screen up. Sometimes I share all kinds of things, so hopefully this is not the case. Okay.
Looks perfect.
Okay, all set. Okay. So what I will be talking about this evening is sexual health as it pertains to multiple myeloma. I've entitled it Regaining Intimacy. And let me just move my pointer. Okay. I have no financial relationships to disclose. That's just the business of starting a lecture. The objectives of this discussion is to learn about sexual health, the etiology of sexual dysfunction, learn a little bit more about prevalence rates in cancer and common sexual issues and treatment strategies. Just to begin, I thought it's interesting to understand the definition of sexual health. So what the science says and what we see in the media. So what the science says is sexual health is fundamental to the overall health and well-being of individuals, couples, and families, and to the social and economic development of communities and countries. Sexual health, when viewed affirmatively, requires a positive and respectful approach to sexuality and relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. That's from the WHO. Sexuality is an inherent, essential, and beneficial dimension of being human as well. If we look at what the media says, and I put up a couple of different pictures here, the media is very skewed. In looking at individuals that may be a little bit younger, very seductive poses, many of them partially or underclothed. And for folks that are a little bit more mature, shall I say, very happy, very smiley, clothed, beautiful gray hair, beautiful smiles. We have a very different view, a very skewed view, in my opinion, of what sexual health looks like throughout the aging process. So what sexual dysfunction is, our sexual response cycle is typically made up of a desire to be sexual, some period of excitement or buildup of arousal, climax or orgasm, and then resolution. So what sexual dysfunction is, somewhere along this sexual response cycle, something is not going in the way that it's supposed to go. And it is also very distressing to the individual that is experiencing the sexual issue. What we know in terms of where sexual dysfunctions may stem from, certainly from illness or disease, like multiple myeloma itself, treatment-related side effects. I've just listed a few there. There's plenty that include things like being really tired or fatigued. And again, fatigue in cancer is very different from fatigue at the end of a workday. You all know what the experience of fatigue is like and how difficult it can be to function. Feeling weak, having pain, different weight changes, and the emotional side effects too can contribute to sexual issues. Being depressed, and we know that depression is greater in cancer. Being anxious, feeling worried about the disease, feeling worried about the different symptom presentations, feeling worried about, is it going to work this time? If we try to be intimate, is it going to work? Am I going to feel okay about how I look, how I feel? Are there going to be any issues? Certainly changes in how you feel about yourself, how you feel about yourself when you look in the mirror, but also how you feel your partner may perceive you. And I always like to mention grief and loss. There's various losses throughout the cancer journey that patients all experience, whether it be the loss of a normal role, a daily role, whether it be loss of a physical function, loss of changes in that relationship with one's partner, loss of sexual function, and a whole host of other losses. So there's a grieving process that goes on with cancer too, that is often very much under addressed, but certainly related to the development of sexual issues. So what does sex and cancer have to do with each other? Well, the research tells us that about 50% of cancers directly affect sexual organs, cancers like breast cancer or prostate cancer, and a little bit more than half of those half of cancers in general indirectly affect sexual function. So what this means is that cancer does not have to affect a sexual organ to affect sexual function. And almost all cancer treatments have the potential to alter sexual function, whether it be surgery, chemotherapy, radiation, hormonal therapy, immunotherapy. Any number of things can certainly interfere with sexual health. What we know about sexual function in cancer is that 40 to 100% of survivors experience sexual difficulties during or following cancer treatment. The majority of survivors do not receive the support for sexual problems and are not prepared for dealing with changes in sexual function, body image, and/or intimacy. And we know that sex ranks consistently among the top 5 unmet needs of survivors. This topic becomes kind of the hot potato between patients and their medical providers. Who's going to ask first? How is it going to be asked? From patient side, does the doctor have the time to listen? What kinds of questions should I ask? I feel kind of uncomfortable addressing these questions. And from the provider side too, I'm not sure if I should ask. This may make the patient feel uncomfortable, or maybe I don't have the training in this area and I don't know who to refer the patient to. So there's lots of barriers that get in the way, but we do know this is consistently a very important topic and one that is often under addressed. Remember that number, I said 40 to 100% of cancer survivors have some type of sexual issue. Just to compare that number to individuals in the general population, we know that about 43% of women and about 31% of men throughout their life will complain or will have some type of sexual issue. And this number certainly increases with age. So it is less for individuals who have not gone through any cancer treatment. One of the other differences for cancer patients is it may not be such an issue of, I want to regain sexual activity. I want to be able to have intercourse again with my partner, as much as it is, I want to feel close to my partner. I want to feel physically intimate with my partner. Cancer patients strive and long more for that connection, and that may be a little bit different from what's in the general population. Some common sexual issues that patients talk about are things like erectile dysfunction, vaginal pain or vaginal dryness. Hence the picture, this is supposed to look like a desert. I hope it does. And certainly for both men and women, things like low libido. So I wanted to talk a little about each one of these and where they may come from. So sexual dysfunction, like erectile dysfunction. So really, a one-time experience with any erectile issue can cause what we say a negative experience. And what happens is the person may start to anticipate that this is going to happen again and start to get anxious about it. If one is anxious about being able to perform sexually, what happens is the blood vessels start to constrict. So it's almost like this real, I'm exaggerating, real tight. The blood vessels constrict. Blood flow is not going into things like the extremities, like the hands and feet. They may become very cold, but blood flow is also not going into the penis, making the erection very difficult. So this may be more, we say, in your head, more that there's anxiety and fear and emotional issues that get in the way. And it's how your body and your mind react to that can contribute to things like loss of erectile function, where an individual then becomes more and more anxious, and we call that performance anxiety. For women, sexual dysfunction like vaginal dryness and sexual pain often come hand in hand. So if there's something like vaginal dryness, which again is very common, often a side effect of medical treatment, often just a normal process of aging or menopause. So if there's an experience of intercourse and there is painful intercourse, again, it's this same anticipation of, is this going to hurt again? Geez, and if it hurts, who would want to do something that hurts? Well, I want to do this because I want to feel close to my partner. I feel guilty that my partner has done so much for me, and I want to be able to do this. So there's this pain there, but okay, you go through, you push through it. But the body responds to that pain again, just as in the previous slide. If there's something like painful sex, the pain then reinforces kind of this tension in the body, making sex very difficult or painful. And what happens as a result, it may be a very negative experience. A person may become avoidant of sexual activity or intimacy. A person may start to have lower desire for sex. Again, who would want to do something that hurts? And that avoidance of intimacy is not just as it pertains to sexual intercourse itself, but avoidance of all kinds of intimacy, holding hands, hugging, sometimes sleeping in the same bed. Many individuals will say, I don't want to do those things because I don't want to lead on my partner. I don't want to feel bad. So what I do is I start avoiding. So I would used to say, when I met with couples in person, I could always tell if there was something going on, if they were sitting close together on the sofa or if they were sitting, further apart. That always is an indicator to me, like there is some fear, there's some underlying concern or some issues going on there. So there's a cycle here too, and it's very easy to get stuck in this cycle. So for most patients, all patients, lack of libido is really a top complaint here. Often not just one issue, often a combination of different issues. So I listed a couple of different things here. You may have some other ideas too. Stress, weight changes, fatigue, weakness, medication. Medication can contribute to low libido and other sexual issues, especially medication for treating depression or anxiety. Medications are very useful for treating mood disorders, but some of them can also contribute to things like low libido, erectile issues, and also vaginal issues. The cancer treatment itself, relationship issues. Oh boy, this is a big one. Couples don't realize if you're arguing with your partner, or there's a past conflict that was never resolved, sometimes there's this underlying resentment that builds up, and it's this underlying resentment that can contribute to low libido too. Depression or anxiety, and certainly any other health issues, things like diabetes, for example, can contribute, as well as many other things. So how do we deal with things or sexual issues? Thankfully, there's many ways to help. So I want to go over a few of those. Number one, you got to talk. You got to talk if you want to walk the walk. So the little comic here on the left says, what do you want, Denise? I'm not a mind reader. Absolutely. Our partners cannot read our minds. So it's important to learn how to have this conversation. I do recognize this is very sensitive, very vulnerable topics, and there is great concern about how our partners may react. But I assure you, if it's communicated positively, without criticism, if it's communicated at a time when stress is low, it can be very, very useful. So some suggestions are talking to your partner, sharing fears about resuming sex. And this is not just for patients, but this is also for partners that worry that they're going to hurt the patient. Taking things slow. Offer non-sexual comfort and reassurance through holding hands, hugging, or maybe just gentle massage. None of this has to be unclothed. Everything can be clothed. It's really whatever you feel comfortable with. Taking the time to plan ahead and be inventive. Planning ahead gives you a chance to recognize when you feel more energetic, when you're not tired, when you're not stressed. It's not a bad thing to plan a little bit ahead. Now, not everybody likes to hear that, and I'll explain why in just a moment. Another thing that's important in understanding is what we call the dual control model. Men and women, male body, female body, we think different. Men tend to use more sensitive gas pedals. So men are traditionally or more visual. So there may be something that they see that they like that feels very arousing. Maybe it's an experience they had. Maybe it's something they watched on a program, erotic material, something like that. They tend to be very sensitive gas. Oh, you look really nice. Wow, I'm so attracted to how you look. This is what I mean by gas pedals. Women, on the other hand, have more of what we call sensitive brakes. So women tend to be less on those things, not to say that they can't experience the same type of gas pedals, but where women get stuck is, I've been home all day, or you've been home all day and I've just come home for work and you have nothing made for dinner and the dishes are still in the sink and you forgot to, I don't know, you forgot to, call the insurance company up. So women, these are the breaks. This is when women say, how can I possibly want to be intimate with my partner? She didn't do any of the things that he was supposed to. So women have what we say more sensitive breaks. The goal here is really just to understand each other, understand what are those things that we call the turn-ons, and understand what are those things we call the turn-offs. Often it's the turn-offs that create a lot of sexual discrepancies or sexual discord between couples. So again, talking is very, very helpful. There's also unrealistic what not myself, but some others have defined in the literature called sex expectations. Just because treatment is over, just because you maybe have a good day and you feel good, doesn't mean it may be time to be intimate. Again, really understanding what it feels like, understanding how you're feeling, not only for patients in terms of their own body, their own mind, but together as a couple, what that looks like. So this is the one I wanted to get back to when I said about planning. And yes, often patients do not like when I say, well, you may have to plan. And I will hear, well, I want things to be spontaneous. They always were spontaneous. So spontaneous desire is something that often occurs in the very beginning of relationships, right? Brand new, getting to know each other, just attracted, like we see in the movies. You can run and, you're so excited to see each other and just, so incredibly affectionate. That's spontaneous desire. Again, often beginning of relationships. As relationships grow, as time passes, we have what's called more responsive desire. And what that means is you're responding to something. You're responding to a nice gesture that your partner did. You're responding to a way you were touched. You're responding to maybe some nice romantic music that you like, or you had a nice evening out. You're responding to something that creates the desire that you then act on. So when I say plan, I'm looking more at a responsive desire. And I see responsive desire, and I will often tell couples that I work with, probably, kind of those first couple of dates you went on, you probably thought about what you were going to wear, where you were going to go to eat, maybe how much time, what kinds of lotions or cologne that you wore. So there was a planning process going on. Remember that? This is very similar. There is a planning process. We just maybe don't identify it that. So spontaneous desire may still occur, but it's more likely responsive desire. Another thing that's really important is taking time to achieve a satisfactory degree of stimulation before beginning intercourse for men and women. No rush. Often when men have erectile issues, they want to rush and get through it because they're so happy to have an erection that they are really fearsome of losing it. So they hurry up and want to rush. Doesn't work, it may not be the best method because if the partner isn't ready, then it can create some issues. Using a lubricant, so I just put a couple of different ones here. It's called Lube, and sometimes it's what's in your kitchen. This is coconut oil. This is very popular as a lubricant. So there's lots of different lubricants, certainly there's plenty of things in the pharmacy. You can order online as well if you're not comfortable going into the pharmacy, but there's water-based, there's silicone-based, and there's all natural and organic-based lubricants too, like the coconut oil. And again, certainly for men and women, arousal time varies. It doesn't mean you're not attracted to each other. It doesn't mean that desire is very different. It's just that men are able to get aroused a lot quicker than women. And this is where I said, take the time and recognize for each of you that arousal time is different. It has become one of my favorite shows in the pandemic. And I just put this up because I think it's, finally there's a lot of programs out there today that are very comfortable with addressing sexual health issues. In this clip here, this was about one of their products for any of you that have seen, I think it's Grace and Frankie, using a vibrator. So again, as relationships change, as our bodies change, as the aging process, as we mature, we may require different types of stimulation to produce that same type of arousal. And there are lots of tools, and actually today they're called sex tech, not sex toys, sex tech, because many of these things can get hooked up to your smartphone too. But things like a vibrator can be very helpful in producing arousal, producing orgasm, and they are available for both men and women. When there's pain involved in intercourse, something that I often recommend is considering changing positions, considering, again, it's communication, talking about anxiety, using a lubricant, often avoiding deep thrusting or using more of a rocking motion can be very helpful. Therapy, that's where I come in, or one of the places where I come in. On the first circle that you see is cognitive behavioral therapy. So it's often what many psychologists are trained in, is cognitive behavioral therapy. So understanding how your thoughts trigger feelings and trigger behaviors. So if the thoughts are like, I'm really worried that sex is going to be painful, the feeling may be anxiety, and the behavior may be avoidance. So I use a lot of, as others like myself, we use a lot of cognitive behavioral therapy to really understand this process, to help you understand how this cycle continues, and then certainly to help understand what we can do about it. Lots of medications available today for men, but also for women. Viagra has been all around for some time. I'm not sure how many years now, but that is just one of a few medications to help produce erections. And I would just say here, be very clear with your provider how to use it. That's one of the mistakes that I hear a lot of patients saying. When I ask, well, how did you take it and how many did you take? Sometimes there's some confusion with that. So always clarify with your provider, how should you take it on the empty stomach? Should you take it on a full stomach? How many, what the dosing is? Can the dosing be changed? Sometimes just for reasons of that, of taking it incorrectly, it may not work. And then also the medication isn't what we would say, a magic pill. If your brain, if your mind isn't sexually stimulated, if you're not feeling desire, then the pills may not work. So desire has to be present there as well in order for the pills to be effective. And certainly, as I said, there's quite a few different pills available for men, and often it's the first line of treatment. For women, there are a couple of pills just very recently on the market. Does not have the same degree of effectiveness, at least that's what the data is showing us today. The good thing is it's helping start the talk. It's helping get the word out. It's helping patients feel more comfortable saying to their provider, I read about or I saw on TV, I'm having that issue. What do you think? And I'm also a sex therapist and using, cognitive behavioral, but also very specific sex therapy techniques. Anything that I discuss with patients or with couples, we discuss in session. They may go home and try some of the suggestions or recommendation. And then we come back in the in-person, which is now video session, and discuss successes or non-successes of these techniques. One of, just to branch off from cognitive behavioral therapy, one technique that is used both for cognitive behavioral therapy and sex therapy is what we call mindfulness. Some of you may already be practicing this. Mindfulness is a technique that helps you stay present without judgment and really to be kind to yourself. When you're anxious, when you're feeling nervous about something, very easy to get, what I would say, to get stuck in your head up here. The mindfulness techniques helps to bring your awareness to the present by focusing on things like your breath. And by doing that, those thoughts that are there, those worrying thoughts just kind of fade away. So this is a practice. You probably have heard of various apps. If you've flown on any airplane, it seems some of the airlines do have that as part of their program, some different meditation or mindfulness apps to use. Many of them are free. I know many of the cancer support centers, offer some seminars in mindfulness. It's an excellent tool to have. You don't need a lot of time to practice. Can be as easy as 3 minutes, and can be as long as, whatever you want it to be. But it's really about paying attention in the moment, because when you pay attention in the moment, all those thoughts there just naturally fade on their own. And then the cornerstone of sex therapy is what we call Sensate focus exercises. And this is often something that I will recommend for couples. When there's fear, when there's anxiety, when there's nervousness about, how do we reconnect again? This is a series of different exercises practiced at home, starting with the really basics and then working our way up. We agree up front, or couples agree up front, this is not about intercourse. This is not about engaging in any intercourse. So sometimes just taking that away, you could just see, the relief go over couples and individuals' faces, because again, taking away that worry, focusing on connecting again, and focusing on connecting through very heightened sensory awareness of touch, sight, sound, and smell. So couples go through a series of different exercises. It's not massage, it's just lightly touching. Each partner takes turns. It's for a set amount of time. Can be, for 5 minutes, can be for 15 minutes. Clothed or unclothed, it's really whatever each individual and the couple feels comfortable doing. And then gradually, week by week or every other week, we start adding in more body parts. So in the beginning, it's very benign. And as you go forward, you add in, you may feel more comfortable touching organs of sexual response, and certainly continue to work the way up. But again, this isn't about intercourse. This is about reconnecting. This is turning off phones, TVs, any connection, and just restarting the intimacy process. So what makes sexual side effects so unique then? So unlike other treatments related to side effects, sexual issues do not improve or resolve with time. If untreated, sexual issues will tend to worsen with time. So you probably know, those of you who've gone through treatment, that it takes time to feel rested again, that it takes time to get your energy back, or your stamina, or maybe even your appetite. This is one of those things, sexual issues, that just don't automatically get better with the passage of time. Usually we have to address some issues. Usually we have to talk about some issues. Usually we have to figure out what exactly is going on and understand what we can do about it. So again, sexual issues are often associated with things like anxiety, depression, how you feel about yourself, how you feel about how yourself can function, loss of what we call loss of perceived self-efficacy. And again, that grief or loss that can be very variable throughout the process of survivorship. Getting help. Many times individuals ask me, like, what questions do I ask? So I put down a few different sites that I find very useful. So this one here, Women Lab, is not just for women. It's from the University of Chicago, where I'm from. There's a section on there. There's lots of informative information, but there's a section on there about questions to ask your doctor about sex and cancer, how to get it started. Even saying things like, I notice how I feel. I used to have desire before I started treatment. I don't have that same desire. Do you have any suggestion? So there's a whole list of different questions there. If you're specifically looking to meet with a psychologist or a counselor that specializes in sexual health, the organization is called ASECT. That's the abbreviation. And on the ASECT website, it's asect.org. You can put in the state you're from. You can put in a specialty, and it will list all the providers in your area, will list what insurances they take, their hours, their private practice, or with a different setting. So those are a couple of very helpful resources. And I just want to bring your attention to the middle too. Sex and cancer is being talked about more. Thankfully, it's about time. There's more articles addressing these issues. Some have very helpful information, maybe some mediocre, but the topic is out there. And again, great leadway into with your doctors. I saw this article, I heard about this. How do I get the same kind of help? And many of these have resources too. And again, certified sex therapists, that is what I am. Beneficial resource for anyone seeking to preserve or recover the sex life they desire, and really have made it part of my mission, something I very much advocate for, and why I went ahead and received this specialized training in this area. I had so many patients talking about these issues. When I started to ask the question more, I started to get more of a response. And just asking the question, providing numbers, providing resources, and now being able to provide the therapy, just so relieving for so many patients that they have a place to go. So really, these are some great resources. I encourage you, if you're interested, to please seek those out. And with that, I will thank you, and I'm very happy to take on questions. And I'm going to stop my screen here. Okay.
Thank you so much, Amy. I appreciate all that you do. It's been so I've been trying to find someone like you for a long time for a patient, and I hit the jackpot. And it's important to open up and ask these questions, and because especially depending on the demographic of where we all live and grow up, this can be a taboo topic that a lot of people don't feel comfortable asking and sharing. So I love that you do that, and I appreciate it. So I'm going to invite everyone to put any questions that you may have for Dr. Siston in the Q&A. It's at the bottom of your screen. As you put in your questions, we will answer them. But I do have a couple questions that I will ask to get things kind of going. Okay. So between caregivers and patients, how do you bridge that gap or switch roles from caregiver to intimate partner? Like, any tips that you have for people to kind of change that hat and to build that relationship?
That is a great question, and that's often a concern. Patients have seen, or caregivers have seen their partner in a very sick role if they're the patient, and it's hard to see them in a different way. And patients have seen their caregivers, their partners, in a caregiving role doing so much, and it's hard to make that change. I often say, talk with each other about what you used to like, what you used to do, how you used to be physically and emotionally connected, and how to get back to that way. Just starting the conversation and admitting it's hard. It's hard to see you and not remember seeing you in the hospital. But I think if you open up that door, you will see it. There's concerns from both sides. And that's one thing I always tell patients: check in with your partner, check in with your caregiver, because you know what? Not many people are doing that. And just to say, how are you doing with everything, really helps to start closing that bridge that may be there.
I love that, because I feel like often we're always asking the patients, like, how are you doing? How are you handling everything? And the caregivers are often the person we don't ask that question to. And a lot of times they're struggling, and they have to hold it in because they feel like, if I express that I'm struggling, then I'm not being supportive. So when it doesn't mean that, it's
not at all
to struggle.
Not at all. And if you don't take care of yourself as a caregiver, you can't help your patient or your partner. So very important. Sorry, go ahead.
So we have two questions. One is asking, what is the name of prescription for women?
So there is a couple of them, and I hope I don't forget them. Not the clinic name is called Addie. And the other is called, it begins with a B, and I'm sorry, I can't think of it. So there's two right now that I know of that are on the market.
You can always email that to me and I can send it out with them.
Sure.
That way we can get that, so they can ask that question.
Yes, exactly.
Another one is, what can you do if one partner is wanting to initiate sexual intimacy, but the other doesn't have any desire?
Okay. This is often a very common problem too. And that person that is initiating, and if the other person doesn't respond to that or rejects that initiation, it makes it harder for that person to go ahead and initiate again. They kind of start withholding and avoiding that contact too, and can get fairly isolating. I think if one person is initiating and you're not ready to respond to that, it's saying that I'm not up to it. I'm not feeling up to it right now. Maybe we can aim for, over the weekend when we're less busy and it's less stress, let's create some time for that. So it's not just about saying, recognizing yourself, expressing that it's not the best time, but then I always say, like, maybe creating a different space, like let's try another day. How about see how it goes that day?
Yeah, I like that. Creating that, allowing yourself to mentally prepare for what you can or want to do
Mm-hmm.
can often help create that desire
Mm-hmm.
rather than that spontaneity.
Yes, exactly. Yeah. And if we have time, Lindley, just, if there's time, and I can do also a very short 3-minute breathing mindfulness exercise if we want to keep that before we close out.
Yeah.
Okay.
Do you have another question?
Sure.
Some myeloma medications have the side effect of neuropathy in extremities. We talk about feet and hands, but do men have 5 extremities?
I don't have a medical answer for you there, but I have had patients also talk about feelings of numbness, sensitivity in their penis too. So if you could, I would say check with your medical doctor, but I have had patients talk about this too.
I've heard of that one as well.
Mm-hmm.
And I've heard there's like some new things that create stimulation and that can help reduce that numbness. But
Mm-hmm.
I'm not sure what exactly that is. So I have
Mm-hmm.
heard that as well.
Yes.
To answer
Okay.
that question.
Okay.
We have another question. What do you do if you want to be intimate, but you have no desire and haven't had desire?
Okay. So if you want to be intimate, there's a little bit of spark there. In cancer, it's fairly common to have low desire. So I will say, if you want to create that space together, go ahead and create that space. Get started into some type of intimacy, whether it's using your imagination, fantasizing, viewing or reading erotic material, engaging in, massage with each other, anything like that. Typically, once you start engaging in some type of intimacy, the arousal will start to build and you will find there's desire there. That's that reactive. You're reacting to something. So that's more of the reactive desire. So again, very common in cancer, low desire. Some say zero desire. I say flat or blunted desire. But once you start, even if you're not fully there, once you start, the reactive desire likely will kick in.
Yeah, I think that can go with this other kind of question that we have in the chat. Says, I've never been very interested in sex even before cancer. It got a lot worse after I started my treatments 11 years ago. My husband never lost his libido. I just don't have desire, and sometimes he gets very upset because I don't initiate any type. We argue a lot, and it seems he wants sex to make him happy. So how this kind of, I've heard of this kind of a lot with a lot of different people in illnesses and everything is, so how can you take this kind of moment where they're wanting to initiate, but the other party doesn't, and, kind of switch gears without offending?
Right.
Like still showing that love to them without creating an argument.
Yeah. And this is hard because if you're not feeling it, you're not interested, it's hard to put yourself in that place. I definitely would talk with your partner about that. Understanding that it's normal in relationships to have different levels of, or to have discrepancy in sexual desire, some high, some low, some, and some, fairly close to each other. So that's fairly normal. Talking with each other about where you can meet a little bit more in the middle. Maybe it's not intercourse, maybe it's, some other type of playful sex, maybe it's something that you do mutually to feel aroused, can be what we say, maybe more of a compromise. But again, talking and this is not unusual to be different here. Many women will engage in intercourse, or maybe men will engage in intercourse too, because they know it makes their partner feel good. I always say, like, what makes you feel good? Because if you're doing that, you're going to grow more resentful. And that motivation to engage in sex the next time is not going to be there. You're going to be more angry that I did that, or it wasn't what I wanted, or maybe even a very positive experience will say, okay, the next time he initiates, I remember that was really nice. I'm going to go for it. So communicating, maybe compromise, can be very helpful.
All right, we've got 2 more questions here, and then we'll go over those mindfulness.
Sure.
When my Revlimid prescription is prepared to be sent, the provider is empathetic about wearing a condom if I'm having sex with a woman of childbearing age. But are there any issues about the exchange of bodily fluids, oral sex? Would it matter during different days of a 14 on, 7 off schedule?
I am probably not the best person to ask that question.
I would say ask that to your doctor or the pharmacist.
Yes. Yeah.
All right.
Sorry.
No, it's okay. We can get that question answered another way. I want to have sex, but then because of my meds, I have bad GI issues. They really get in the way of our ability to follow through. I feel like I'm disappointing my husband. How can I explain this?
Oh, okay. If there are GI issues, and I don't know to what degree of GI issues that you're talking about, but again, really paying attention, and maybe some of these GI issues are unpredictable and you just don't know. I always say, have a towel next to the bed. Have, if you need to put any kind of pad down on the bed, if that makes you feel comfortable, talk about, like, I can't control these things. Sometimes this happens. Is this okay with you? If the GI issues are a little bit more predictable, then yes, planning can be very helpful, because you could work around those times when there may be more GI upset.
Yeah, especially if you notice a time frame of when, like, from when you eat or drink and you have issues. If you notice that time frame, you can kind of plan. That's what I would think.
Yeah.
All right, let's go ahead and have you show us some of the mindful tricks that you recommend.
Okay, so I have to put my cheaters on here. For the, this is a very brief, just a 3-minute demonstration of a breathing mindfulness exercise. So with any mindfulness exercise you do, what's really important is you want to be sitting up straight with your, if you're in a chair, with your back towards your chair or your back upright, but not in the position where you'd be kind of tense, a relaxed posture. So all you have to do is listen to what I'm going to say. I'm going to specifically instruct you when to close your eyes, when to open your eyes if you're comfortable. Just kind of keep your hands maybe at your lap, on your side, or on your chair, on your sides, whatever is comfortable, and we'll go ahead and start. Okay. So what we're going to do is a brief meditation now. It's called the 3-minute breathing space. The first thing we do with this practice, because it's brief, and we want to come into the moment quickly, is to take a very definite posture, relaxed, dignified, back straight but not stiff, letting our bodies express a sense of being present and awake. Now closing your eyes, if that feels comfortable for you. The first step is becoming aware, really aware, what is going on with you right now. Becoming aware of what is going through your mind, what thoughts are around. Here, again, as best as you can, just noting the thoughts as mental events. So we note them, and then we note the feelings that are around at that moment. In particular, turning toward any sense of discomfort or unpleasant feelings. So rather than trying to push them away or shut them out, just acknowledge them, perhaps saying, Here you are. That's how it is right now. And similarly, with sensations in the body, are there sensations of tension, of holding, or whatever? And again, awareness of them, simply noting them. Okay, that's how it is right now. So we've got a sense of what is going on right now. We stepped out of automatic pilot. The second step is to collect our awareness by focusing on a single object, the movements of the breath. So now we really gather ourselves, focusing attention on the movements of the abdomen, the rise and fall of the breath, spending a minute or so to focus on the movement of the abdominal wall, moment by moment, breath by breath, as best as we can. So that you know when the breath is moving in and you know when the breath is moving out. Just binding your awareness to the pattern of movement down there. Gathering yourself, using the anchor of the breath to really be present. And now, as a third step, having gathered ourselves to some extent, we allow our awareness to expand. As well as being aware of the breath, we also include a sense of the many individual sensations in the body as a whole, so that we get this more spacious awareness, a sense of sensations in the body as a whole, including any tightness or sensations related to holding in the shoulders, neck, back, or face. Noticing the sensations of the breath and the body as they emerge, linger, and fade away. Holding them in this slightly softer, more spacious awareness as you breathe in and out. And then, when you are ready, just allowing your eyes to open.
Thank you so much.
You're welcome.
We really appreciate you sharing your expertise, your skills to help us to be able to communicate better in our relationships. It's definitely so vital for creating a safe space in your home and feeling love and showing love.
Yes.
So thank you so much. I'm going to share my screen to end. I just want to make one last note is that with it being Valentine's Day or Valentine's month, I want you all to focus on how you can show love to those around you and help kind of show that love to your spouse in whichever way. There's gifts, there's service, there's intimacy, as well as kind words. And I think there's another one I may be forgetting, but I think it's important to remember to do those things to everyone, with everyone around you. So our next chapter event will be on March 9th. We are going to be focusing on turning daily activities into exercise and how you can do what you can and enjoy it. So we will have Master Gardener Peggy Scott be talking about plants, gardening, and how it can be benefit of having plants in your home as well as spending time in your gardens. I will also go over our soon to be launched HealthTree Moves fitness app. It will be replacing the Move Spring, the app that we have used in the past for our March fitness challenge. You may be interested in other myeloma crowd community events that we have coming up. We have one Thursday, February 3rd at 1 p.m. Eastern, stem cell transplant chapter, vaccinations, post-transplant patient experience. Tuesday, February 8th, the SoCal Myeloma Community Chapter. We'll be talking about the CAR-T update and Q&A. Wednesday, February 9th, 1 p.m. Eastern, connecting with Myeloma Crowd Chapter, finding solutions for your side effects. As always, I would like to thank our sponsors without whom this would not have been possible. Bristol Myers Squibb, Amgen Oncology, Genentech, AbbVie Biotechnologies, Sanofi, Janssen Oncology, Karyopharm Therapeutics, Takeda Oncology, and AbbVie. And thank you all for helping us build a strong myeloma crowd community. We appreciate you, and we are so grateful for Dr. Siston to help us today. And you guys, I hope you all have a great day.
Bye, thank you.
Thank you.